We will be presenting a case on extraperitoneal robotic-assisted excision of eroded bladder mesh with the Vinci single-port robot. This is a 63-year-old female with a history of a retropubic midurethral sling in 2007 presenting with recurrent UTIs and dysuria. In 2015, the patient underwent a cystolitholepaxy of a bladder stone and was found to have a mesh erosion within the bladder at that time. A recent bladder ultrasound demonstrated a 1.8 centimeter non-mobile calcification along the left lateral bladder wall. Office cystoscopy confirmed a bladder stone on the left lateral bladder wall with mesh visualized on retroflexion. Video urodynamics were performed, which demonstrated no evidence of bladder outlet obstruction. The patient underwent single-port extraperitoneal robotic-assisted excision of eroded bladder mesh with bladder stone removal. The patient was placed in a supine position. A 4 centimeter curvilinear incision around the umbilicus was made. We dissected down through the subcutaneous tissue, and once fascia was entered, the space of Retzius was bluntly dissected in a manual fashion. A small wound protector was placed, and the robot was docked. The abdomen was insufflated to a pressure of 10 millimeters of mercury. We proceeded to further develop the space of Retzius by dropping the bladder, remaining extraperitoneal in our dissection. As we approached the left lateral aspect of the bladder exterior, the mesh was visualized. The mesh was dissected down to the level of the bladder using a combination of both blunt and sharp dissection. Intraoperative cystoscopy was performed to identify the bladder stone and the precise location for the cystotomy. A 3 to 4 centimeter cystotomy was created and the mesh was removed along with the calculus. The bladder was closed in 2 layers. 3-0 Vicryl was used to close the mucosal layer in a running fashion. A 2-0 V-lock was used to close the seromuscular layer in an imbricating fashion. After cystotomy closure, the bladder was filled with 250 milliliters of methylene blue diluted in normal saline with no extravasation of fluid. A cystoscopy was performed and several mesh fragments were removed from the bladder. The port site fascia was closed with a 0 Vicryl in a running fashion. A 2-0 Vicryl and 4-0 monocryl were used to close the subcutaneous and skin layers respectively. The total operative time was 150 minutes. The patient experienced an uneventful post-operative course and did not require narcotics. On post-operative day 13, a cystogram was negative for extravasation and the Foley catheter was removed. The patient has had no recurrent UTIs or bothersome lower urinary tract symptoms since surgery with excellent cosmetic results. In conclusion, a minimally invasive extraperitoneal approach for eroded bladder mesh excision is feasible by insufflating the space of Retzius. The single-port robot is well suited for this purpose through a single trocar site without the need for steep Trendelenburg positioning. Finally, excellent wound cosmesis and postoperative recovery can be achieved. Thank you.